Welcome to the webinar Digital Workflows for Implant Planning, Placement, and Restoration in the Aesthetic Zone. It is being presented by Dr. Dominic D'Amico, and we will begin the webinar shortly. And with that, it is my pleasure to introduce Dr. Dominic D'Amico. He graduated from Boston College with a BS in biology and received his DMD degree from Tufts University School of Dental Medicine. Dr. D'Amico is an adjunct instructor and lectures on CAD/CAM dentistry. He lectures on digital dentistry, 3D planning, restoration, and placement of dental implants. Dr. D'Amico started a private practice in his hometown, Watertown, Massachusetts, where his interest in digital dentistry led to the integration of digital design, manufacturing technology, CBCT imaging, and guided implant placement. Dr. D'Amico grew his expertise by adding 3D printing technology, and his practice has now completely embraced digital workflows. And now I get to say, take it away, Dr. D'Amico.
Thank you, Jessica. Thank you. Thank you very much. So a few more housekeeping slides, I guess. Just affiliations and interest. I am a consultant for Dentsply Sirona and a KOL, and I do speak for them in terms of implant placement and CAD/CAM dentistry. And the last one, there is no financial or in-kind support from any commercial or other organization for this presentation. So I thank everybody for being here tonight, and I hope you had a great day. I've been in practice for 30 years, and I had one of those humbling days where we were going to start our morning. We had our morning huddle, and then my hygienist comes up and says to me that her cuspidor is backed up. And very blessed to have my son in practice with me, and he looks at me and he's like, what do we do? And I'm like, we have to go down and clear out that backup unless we want to lose a day of hygiene. So that's how my day started, was cleaning out our cuspidor for our hygienist. So I think it was a great learning experience for my son, getting to see that we do a little bit of everything, including plumbing. So I hope you had a great day, and I thank you for being here. I know it's a little bit tough after work and in a webinar setting, so I hope that I can be a little bit engaging, and maybe we can ask some questions and have a little bit of a back and forth as much as we can, being on a webinar. But my practice has really evolved into a fully digital practice, and in 2008 I integrated CAD/CAM technology, and then in 2014 cone beam imaging. And I'm proud, I think, to say that in the last 3 years we have not needed to take a single impression. And I always say, for good or bad, for my son who joined me in 2020, he has not taken a single impression. And I say good or bad because I don't know if that is good or bad, but as he reminds me every day, it hasn't been an issue yet. So what I hope to do tonight is really just kind of share with you my enthusiasm for CAD/CAM dentistry and digital dentistry, and specifically to guided implant planning, placement, and restoration in the aesthetic zone. So if we look at implant success versus implant failure, and I show you this case coming up, and what I want you to think about is implant success or failure, is it long-term osseous integration? Is it aesthetics and long-term osseous integration? And I think our practices, and mine really has evolved into the point where I look at an implant success, aesthetics and long-term osseous integration. But if we look at this case, and she presented to me, and her chief complaint was really tooth number 7 was an old crown, and she wasn't happy with tooth number 10 either. And when I took a retracted view, this is what I saw. So I ask you, is this a success or a failure? What if I tell you that the implant was placed and restored 15 years ago? Is that a success or a failure? I mean, look at that. That implant integrated, but look at that tissue. Look how that tissue migrated. So for me, nowadays, that's really not a success. I think we can do much, much better than that. So we removed that crown, and what I find is that her abutment, there really was no room to create an emergence profile for that restoration. There was not enough tissue there. And this is really the implant. So that implant was placed really at the level of the gingiva. So again, not enough room, not enough keratinized tissue to create an emergence profile, and not a result that we're looking for. If we take a cone beam, what we find is that the implant, there's really no buccal bone, or maybe there was some buccal bone to start with, but that bone quickly resorbed. And if we look at the implant, the diameter of the implant is just too large for that space. And as we like to say, bone sets the tone. And if there isn't enough bone, that tissue is going to migrate, and that's what's going to happen, and that's what did happen in this situation. So what we did was we swapped out that abutment, placed a zirconia abutment, replaced those crowns with some Emax crowns, and this is the result that we were able to achieve. And she was happy with that. And again, her smile line was never really going to show, but I think it was a much better result than what she had. And this is a case that I restored in 2013. This implant was placed, and if we look at the radiograph in 2020, what we see is great marginal bone stability. That bone has stayed there, really has not changed much. But if we look at it aesthetically, here she is in 2013, and look where that tissue is. And that's how I restored that implant. If we look at her now in 2021, this is where that tissue is, and the tissue really stayed there. So again, is it a success or is it a failure? Well, if we look at her smile line, again, it doesn't really show, but if we look at the zeniths of that gingiva, it's just not as pleasing when we look at 7 and 10. So again, I think with today's technology, we can and should be able to do much better. This is a case that we recently restored. Tooth number 7 needed to be extracted. She had previous apical and failing endo, and she just wasn't happy with the appearance of those anterior teeth. Now, through tissue conditioning, temporary restoration in tooth number 7, creating a nice emergence profile, this is what we can achieve today, and I think that this is kind of the benchmark that I like to hold myself to with today's standards. So I'm going to make a statement, and the statement is a digital prosthetically driven plan and guided surgery I think is critical in the anterior region to achieve long-term stability and aesthetics. I think cone beam imaging is critical to successful implant placement and restoration for the anterior maxilla, and throughout the presentation I hope to show why I feel that way. I think a digital prosthetically driven plan is critical to ensure successful placement and restoration for the anterior maxilla. And I think some knowledge of guided bone regeneration, a little bit of soft tissue engineering, and really how do we preserve bone after an extraction or implant placement is really critical in the anterior maxilla. You know, in the posterior, we can get away with a little bit of recession, a little bit of bone loss, but anterior, really there's no place for that to hide. So cone beam imaging, I feel, is critical and really necessary for a three-dimensional view of that buccal bone. Studies have shown that that bone at the mid-root level and at the most coronal level can be very thin. And in this study of 125 cone beam images and examination of 498 teeth, what they tried to do was really to determine and see how thick or thin that buccal bone is. And you can see that in the majority of cases, the bone is really thin, and it's really important to preserve that post-extraction or even with an immediate implant placement. And here again, it ranged from 1.28 to 0.75, and then, you know, and when that tooth is a little bit more inclined, it's even less. So what I look for when I am placing implant, doing my digital design, is what I want to have is really 2 millimeters of keratinized tissue, and I want to have 2 millimeters of buccal bone. And that's really critical. And these are the results that I'm looking for. I'm looking for tissue that's going to create a great emergence profile, a lot of keratinized tissue that's going to really help to support my restoration and the aesthetics of that restoration. And if I look at the early implants that I restored, and most of those, if not all the implants really, were done without a cone beam and without guided surgery. If we look at the long axis of the tooth, as opposed to really where the bone was, most of the surgeons were placing the implants where there was bone. And me and maybe most of you I had a lot of screw access that was coming out facially. inclined. And I think that's one of the reasons why I had so much recession, is those implants were just placed without really knowing where that buccal bone was. So if we look at the third slide, what we see is that the inclination of that implant really should be coming down the long axis of the tooth and coming out more towards the cingulum. With segmentation now of cone beam images, we can really determine and look at what we have for bone. So if we look at this cone beam, we can start to peel away. We can peel away the tissue, and this patient had fractured tooth number 8, and we can even virtually extract tooth number 8. And if we look at that socket, we can really see how fragile that buccal bone is, and how delicate it is, and how important it is to preserve that bone. When we look at studies after post-extraction, what we find is that there's a good amount, a variable amount of alveolar bone resorption occurs after unassisted socket healing, depending on the tooth type. So in our practice, almost all of our cases, there's going to be some type of a socket graft. And my world really is within class description 1 and 2. A full wall defect. In a situation like that, I'm just going to place some allograft material, maybe place a collagen plug or cytoplasm membrane, and just some sutures to hold everything down. Or it's a class 2 3-wall defect and with some dehiscence or fenestration. And that's really the world that I kind of stay in. And cone beam imaging really allows me to predict those types of situations, because if I have a situation in a cone beam that I see and it's something that I don't want to handle, then I'm going to refer that to my oral surgeon. And I have a great relationship with my oral surgeon. He's actually in the same building as I am, and he's a mentor to me and actually trained me to place implants. And that sounds kind of strange that an oral surgeon would train me and then let me be on the first floor of his building. But what we found is it's really a great symbiotic relationship, one in which I know what my limitations are, and I'm able to treatment plan these cases appropriately. And then patients will appreciate the fact that I might say to them, you know what, this is something that's a little bit beyond me, but my oral surgeon can handle this. And we both speak the same language. So it's been a win-win situation for both of us. So the subclassification of socket, what we find is that these situations really will occur. And this is division 1 and 2 of class 2. And what we find is that in a 4-wall defect, again, I'm just going to place allograft, cytoplasm membrane, or a collagen plug. In a 3-wall defect that's type 2-1, allograft membrane with cytoplasm membrane. So what's going to happen is I'm going to place my allograft, and then I'm going to cover that with a cytoplasm membrane. And I'm going to try to tuck that membrane so that it's between the tissue and the bone, and then just suture that. If I have a type 2, then I may use a xenograft. And the reason for that is I just want that graft material to stay in place a lot longer, because it's a bigger defect, and I need that graft material to stay a little longer and not turn over as quickly. And in a situation like this, what I'm going to do is place a collagen membrane and then a cytoplasm membrane, and I'm just going to let that heal. Cytoplasm membrane sutures come out 2 weeks after I've sutured that, and then cytoplasm membrane, I will pull that out at 4 weeks and then let the site heal over completely. So that's just kind of basic socket grafting, something that I do in my practice routinely. So if we look at this case, and this is Molly, this is, again, tooth number 8, need to be extracted, allograft here with a cytoplasm membrane suture, and then this is what it looks like after healing. Nice collagen, nice keratinized tissue really holding its shape, and this is a great site for an implant placement. Within implant placement, these are the scenarios that I look at, and this is kind of my triage tree or treatment planning tree. I'm either going to have an edentulous space that I can say, okay, I'm going to take cone beam, I'm going to take my intraoral imaging and plan for my implant placement, and then I need to decide on, am I going to put a healing abutment, a temporary abutment and a crown, or custom healing abutment. And then I'll have a scenario where it may be an extraction, and I'm going to need to do GBR, maybe some soft tissue augmentation, and then I can go into either implant placement, and again, my flow will be the same. Healing abutment, temporary crown abutment, or custom healing abutment. The other option is an extraction, immediate implant placement, and then again, do I want to place a healing abutment, custom healing abutment, or a temporary abutment and crown? I'm going to go through a few of those scenarios within my slides. I think my method of presenting and teaching is really through case presentation, and I think that's just really the best way for me to show you what we've done and how I do it, and then go through each case individually and the steps that were involved. So the factors that affect that decision in the anterior is lip line, is it high or low? Soft tissue, do I have enough facial keratinized soft tissue? And occlusion, what do I have for occlusal clearance? Is there enough clearance to allow for me to place an immediate temporization? So if we look at a few cases, tooth number 8 in this situation needed to be extracted, and her lip line is right at the zenith of the tissue of that gingival margin of tooth number 8. But when I look and I retract, she has a lot of keratinized tissue, a lot of thick tissue. So this is a case where if I'm going to place an immediate implant, I might be comfortable placing that if my planning looks appropriate. When I look at this case, a little bit of a thinner phenotype, but still there's a fair amount of keratinized tissue, so I feel comfortable even in this situation if I was going to place an immediate implant. And in this situation as well, I think the occlusion favors that if necessary. Well, look at this case. Class 2, and she has a lot of keratinized tissue, but she shows everything when she smiles, right? So this is a case when I'm going to kind of be a little bit more cautious and maybe take a route where I may extract the tooth. In this case, it was tooth number 8 that needed to be extracted. And what I might decide is to do the graft, let the graft site heal, and then go back and do my planning. And when I look at the cone beam in this case, if I didn't have 3D imaging, I look at the angulation of the tooth and then look at the angulation of where the bone is. Right? It's very, very different. So I think this is where cone beam imaging is just so important. Look at that. That's where the bone is. So if we didn't have this technology, that's probably where the implant would be placed, and that would be coming really far facially. And let's look at this case. Low lip line, plenty of keratinized tissue. This patient was having an issue with tooth number 9. So again, this is a case where I would consider extraction and, if conducive, immediate implant placement if possible. So guided implant surgery, I think, can be critical in the successful implant placement and restoration in the interiors. And it's something that I really feel strongly about, so much so that I would say 99% of my cases are placed guided. And if we look at the studies now, there are numerous studies that show that guided surgery is just so much more accurate than freehand surgery. And when we look at this study, what we see is really what they've described as a comfort zone of where that implant should be placed. And that implant should be placed palatally at the cingulum area, and we should be about 1 millimeter subgingival from the CEJ of the adjacent teeth. And I mean, if we're trying to do this freehand, that's so difficult to do. But if we take 3D imaging, we can really, really plan for that. And this as well, this is so critical here, right? We want to make sure that we place implants far apart enough that that bone really has a chance to stay. And if our implants are placed less than 3 millimeters apart, what tends to happen is we're going to have some bone loss adjacent to those implants, which will then cause the height of bone to come down. And we all know that once that happens, we're going to lose that papilla. So it's really critical as far as that 3 millimeter distance between implants. So if we look at what I feel is critical, it's the placement, subcrestal, cingulum area, how far apart they are to each other, and then really the prosthetic design. And what we don't want is we don't want a really big ridge lap. We want to make sure that the areas are cleansable, and all of this will lead to really successful implant placement. So these 3 things I think are critical, and if we have 3D imaging, we can take these things into consideration. So again, if we look at some studies about implant placement, Guided surgery is just much more accurate. And I know I have my oral surgeon, who's a great colleague of mine, same thing. He's placing almost all of his implants guided, and he's now even using robotic surgery. So I just put these studies up here to kind of emphasize the fact that guided surgery really is much more accurate than free-handed surgery. And in the anterior maxilla, it's just critical because you can really refine where you're going to place your implant, right? So look at our planning from this perspective. We can determine that we're going to place our implant 3 to 4 millimeters subgingivally, right? So we can create enough running room, and we can even start to design our prosthetics. If we look at this case, I can start to create or design what my custom abutment is going to look like, what my emergence profile is going to look like. I can look at my adjacent teeth and determine all of my angulations that are needed. So again, this allows an opportunity to really consider the full design from implant to abutment to restoration. So the criteria for successful implant therapy, I feel, are adequate bone quantity and quality, adequate soft tissue quality and quantity, proper implant selection, meaning the diameter and length, prosthetic design, emergence profile, and occlusion. And if you look at a digital prosthetically driven implant plan, it offers you the ability to really make sure that you have all of those things that are necessary for successful implant therapy. So what do we need? We need an STL file. And the STL file is going to give us really our prosthetic design. So that's where we're going to start to create our prosthetic plan. In this case, patient presented tooth 8 needed to be extracted. We need a cone beam image, and that's going to create our DICOM file. And then we need software that's going to merge that information together, the STL and the DICOM, and we're going to create our implant plan. And there are a lot of different choices right now when it comes to implant planning software. My opinion is that most of this will become AI driven, where the information will be fed and AI will know how much bone there is, and it will really plan for the implant placement for us. And then it's going to be up to us to decide, yes, that's where I want that implant, or I need to tweak it. But I think that's where everything will be going into the future. But right now, it's mostly on us. We're going to use either software that's desktop version of software, or it could be online. But that's what we need. STL, DICOM, software, and then we'll create our implant plan. So this is my final implant plan for that tooth number 8. Okay, I can see my bone. I know exactly how much buccal bone I have. I can see how thin it is. And I can create my implant plan. And again, coming out the cingulum and making sure that I fulfill all the requirements necessary for successful implant placement. I'm going to talk a little bit about guided surgery protocols. It's a big topic, but I think that I should at least cover some of the basics. What's really important with guided surgery is what's called D2 value. And what D2 value is, the distance from the top of the guide, the surgical guide, to the most apical portion of your osteotomy. And it's going to be determined differently for different implant systems. But it's very critical to understand what D2 is. When we look at our guided surgery kits, the drills are going to be much longer than our freehand kits. And there's different varieties or different types of systems. There's a key system, sleeve system, and what I'd call a keyless or a sleeveless system. So in a key system, what's going to happen is there are going to be different keys that are going to allow you to choose different drill lengths to get to that proper D2. Straumann is one example of a system that uses keys. Sleeve system, the sleeve is going to be on the drill itself, and it's going to go through the guide. It's a little bit easier to work with the system that has sleeves. You're just not putting as many things in the patient's mouth. But as you can see, the drill lengths can get pretty long. So if you're placing an implant that's 13 millimeters, you're going to use a drill that's 27 millimeters long. And in the posterior, you have to really make sure that the patient is going to be able to open up wide enough to accommodate for that. A keyless or sleeveless, sleeve system, one example is Astra. Keyless or sleeveless system is a situation where the sleeve is really built into the drill itself, and an example of that is MIS and their family of implants. And this is what Astra sleeve system would look like, and that's how D2 is measured. So it's measured from the collar to the tip of the drill, and what they've done is they've reduced the number of drills by allowing you to use a 6 or an 8 millimeter in the same osteotomy in 9/11 and a 13 and a 15. So it's just they've condensed the kit and made it a little bit smaller. And the way that that's accomplished is that when the guide is designed, there's just a 2 millimeter offset within the guide itself. So the guide is either going to be fabricated 2 millimeters deeper or 2 millimeters more coronally, so that you can accommodate the different drill lengths. MIS is kind of a neat system because it allows you to kind of swap and change drill out or osteotomy depth, and you can place a different length of an implant within the surgical field itself. And that's because every sleeve part of that drill is 10 millimeters long, and then the cutting part will accommodate the drill. So it's always going to be 10, and then for an implant that's a 10 millimeter implant, you're going to have the osteotomy or the cutting flutes are going to be 10 millimeters, 11.5, and 13 as you go up for 11.5 implant or a 13. So it's kind of a neat system because you can change within the day of surgery. If you want to place a longer implant, you can do that and still use the same guide that you have. And with Straumann or key system, the keys are just placed appropriately to the sleeve heights. And again, it gets a little bit confusing, but I just wanted to emphasize the fact that there's a few different types of systems out there, and you kind of have to fall into whichever system makes the most sense for you. I stay within systems that either have a sleeve or the drill, the sleeve is on the drill itself. It's just a little bit easier to get into the mouth, not as many parts, and it's a little bit easier to figure out that D2 value. So if we go back to Sheila, and I'm pretty fortunate, I practiced in the town that I grew up in, and I've known Sheila since she was, I think, 10 or 11 years old, and those of you old enough to know what relivio is, Sheila, we were playing relivio, and she tried to jump over a bunch of hedges, and she caught her foot and unfortunately fell on her face, and she had some trauma to 8 and 9, and she had I think she had endo and ortho and everything else, and now she's 50 something, 60 years old, and she needs to have tooth number 8 extracted. So never thought when we were that young that I'd be treating her at this age. But so Sheila presented, and she had a lot of problems with 8 and 9, and I finally decided, I told her, Sheila, really 8 needs to be extracted. She had crowns, temporary crowns, just wasn't working out. And this is what it looked like when the post came out the final time, and this was our STL file, and this is our cone beam, and then we can start our planning. And what I look for in a situation like this, and she really wanted to try to limit or make as few appointments as possible, and I thought it was a good site for an immediate implant placement. So here's my plan, and what I consider when I'm placing an immediate implant is two things. One is I need to be apical to that extraction socket, and I need to be palatal because I need to engage enough bone to get good primary stability. So when I place these implants, if I can get about 30 to 35 millimeters of torque, then I feel comfortable with that immediate implant placement. If I can't, then what I'll do is graft the site and then go back in later. But this site really worked out well. And again, so I'm looking for about 3 to 4 millimeters apical to the extraction site, and I need to engage some palatal bone. So here's Sheila at the day of extraction. Try to do that as atraumatically as possible. Place my implant fully guided, and here's what my implant looks like in place. And I know that I have some buccal space there that needs to be filled with a bone graft. So in this case, it's just an allograft, and I'll just slowly pack it there and place that on the palatal with some type of either condenser, or in this case just a periosteal elevator, and then just condensing that apically. Because she'd already had a temporary crown on 9, I just created a cantilever temporary restoration, put a little bit of a collagen plug there, and just let her go with that temporary restoration. So here's what she looks like day of surgery, right after surgery, with that temporary in place, and you can just see that collagen plug there just kind of hanging out. And there she is with the immediate implant placed. And you can see I'm more apical, and I got really good primary stability here. Now, what I didn't want to do is, because of her occlusion, I really didn't want to place a temporary restoration and load that implant at that day. So here is Sheila after everything is healed. Tissues are looking really good, and I wanted to make a temporary crown to start to really create my emergence profile and really train that tissue to really kind of pop out and create a nice emergence profile. So I just use a temporary cylinder here, and just off of her temporary crown, just drilled a hole in it and just created a temporary restoration for her, and we inserted that. And I like to leave those in place for about 2 months. And I'll do some, I'll check the interproximal contacts, adjust the contours, and really try to push that temporary out as much as I can to really get that tissue to create a nice emergence profile for myself. And if you have enough keratinized tissue, that usually works out well. But again, what we do know is, as I said, bone sets the tone. So if the bone isn't there, you're not going to get that papilla to fill in. So here's what Sheila looked like the day of, placement of the temporary restoration, and this is what she looks like once that tissue is kind of created a nice emergence profile for myself. This is just a custom abutment, gold hue custom abutment, and 2 crowns on 8 and 9, Emax crown, and this is what Sheila looked like at the day of restoration. You can see that that tissue really stays nice, and we get a nice emergence profile. So let's look at a case with an extraction, immediate emplacement, and immediate temporization. This patient presented with tooth number 9. He had some issues. It was extruding, and we take a cone beam, we see there was some internal resorption. And what I did like about this case was that when I looked at it, the root was really wide, and that bony housing was really wide. So I felt comfortable that I could engage enough palatal bone and enough apical bone to get good primary stability. So again, I go through my planning. I want to be exit out towards the cingulum. I want to be engaging palatal bone, and again, I want to be more apical. So this is my implant plan. And again, the beauty of 3D planning is I can really start to envision how I want my final restoration to look. And again, where my vital structures are. Okay, so here's the incisive canal. And what we did here, because I wanted to test having a custom abutment fabricated ahead of time. And what you'll see is there's really an exaggerated emergence profile, and I'll explain to you why that's so. So we extracted the tooth, again, as atraumatically as possible. Here's my implant placement. And here's my final osteotomy. So here's my implant in place. Again, got really good primary stability. Have to graft that buccal bone. But what I like to do in these situations is have a temporary that has a really exaggerated emergence profile. And the reason for that is when I screw that down, that's going to help hold that graft in place. So instead of placing any type of membrane, when I screw this down, that's going to really hold that graft in place. So here's what Jeff looks like at the day of surgery. Here's the implant, implant placed, and here we are temporizing that tooth. And again, you can see that screw retained, and it's exiting out the cingulum. So what's going to happen, really because of that over-exaggerated emergence profile, is you can see that the gingival zenith is different between 8 and 9, because I really kind of pushed on that tissue. So what I'll then do is take that temporary And what I'll do is just shave the facial of that and relieve the pressure that's impinging on the tissue. When I reinsert that, now you can see the distance here. You can see that metal that's showing through, and you can see where the gingiva was. And usually, if there's enough keratinized tissue, that tissue will start to migrate down. And that's exactly what happened. So here's my final zirconia custom abutment, and you can see that that tissue is really kind of falling into place nicely, and now the gingival zenith is pretty much the same in both the areas. So this really kind of highlights, I think, the full gamut of what we're able to do with digital dentistry. So Samantha presented congenitally missing teeth number 7 and 10. And what we did for a period of time for her until she was old enough was, after she had gone through orthodontic treatment, we just fabricated 2 we call them one-wing Maryland bridges. And if you have any CAD/CAM technology in office, they're really easy to fabricate. And that's what she wore. She wore those temporary restorations until she was old enough for implant placement. And she was 18 years old, and this is where we are at this point right now. So when I start to design this case and I look at it, I mean, I think of the power of digital technology, right? If I was to do this freehand and not have cone beam imaging and the prosthetic plan, I don't know if I could place those 2 implants and miss the roots of those adjacent teeth. And look at what's going on facially, right? That bone is really thin, especially in the number 7 area. So ahead of time, I know what I need to do, right? I know that there's not enough bone buccally, and I know that I need real precision placing those implants and not, to avoid teeth numbers, the adjacent teeth there. So here's Samantha Dave surgery and full thickness flap. I'm going to place those implants fully guided. And I know that I need to bulk out that buccal bone. So in this case, again, because I want that bone to hang around a little bit longer, I'm going to place a xenograft material. Place that xenograft, and I placed a little bit of a collagen membrane over and closed everything up. And in this situation, I'm not going to use healing abutments. I'm going to use cover screws because I want to make sure that that tissue really has plenty of time to really mature and keratinize over time. So this is Samantha now when she's ready for uncovering. And when you look, you can really see how much more volume I've been able to achieve between the top image and the bottom image in the green. So I was really able to gain much more keratinized tissue and gain a little bit more buccal volume there. So again, I need to fabricate some custom temporary crowns so I can start training that tissue or really creating a nice emergence profile. So in this case, I just took 2 tie bases, created just a crestal incision, and started to fabricate temporary crowns. What I did in this situation was a little bit difficult to show is I placed those tie bases and actually scanned them, and I was able to capture enough of the tie base itself to create a shell and mill out a shell for each one of those 2 teeth. And again, just using the same technique as in the other case, place some flowable composite, reattached everything, and then just really started to create my the emergence profile that I was looking for. So here she is after uncovering the implants, placing the temporary crowns, temporary abutment and crowns, and just 2 simple sutures on either side. Again, aesthetically, the shades off, but I just want to recreate some emergence profile. So now here's Samantha. Samantha is ready for her final restorations. Again, we've been able to really capture a nice emergence profile. There's a lot of keratinized tissue. Should be able to get a really nice aesthetic result. In a situation like this, if I'm not doing this in-house, then what I'm going to use are abutments that my lab likes to work with. And in this situation, they're true abutments. And it's just easier for labs to use software on their end, capturing analogs or scan posts that are of this variety. So these are true abutment scan posts inserted in those two implants and then scanned. And then here's my final restoration. Again, this is this not me, this is my lab, and this is a custom abutment with their zirconia mesostructure, and this is the result that we've been able to achieve. And this is Samantha after delivery, and this is Samantha at finish. No, again, I thank everyone for participating. Thank you, Jessica. My information is up there. If anybody has any other questions or they want to email me with anything, please do so. I'd be happy to respond. I love talking digital technology, so please reach out if you have any questions.